So Sai, can you share? Yeah, I think Ramandeep's up first. Yeah.
Yeah. Hi, everyone. So this was the case. We were doing a lot of these scleral fixated IOLs before these Yamanes and other techniques took in. So this is a case where one of the haptics which was fixed by the uh, pair pack polypropylene needle breaks up. So you can fix that one using this technique, a railroad technique, which I'm showing with the cartoon. I'll be showing the video also, and it does nice. You don't have to replace the lens. So these lenses are now falling back again, because I think 12, 14 years. That's what people say is the life of the lens. The suture does degrade. So this was a patient where one of the the suture gave away, and we talked to the patient, talked about replacing, and he said, you can let's try this approach. And this was my one of the first patients. You can see that through one eyelet, it went through the long needle and took it out using railroad technique, from the other side using the 2016 needle. And the same the long needle I turned back, and this time I didn't go through the eyelet. I just went. I didn't take, just went through the sclera from the different side, and just came out, and it helps to fix that eyelet which is broken. And this technique can be done where the eyelet is present, but I have tried where the eyelet is not there. Technique does work when you don't want to replace with the newer lens there. Thank you.
Yeah, very, very nice. Let me see. Manish, you can start first and then promote. Just in terms for this case might be different, but in general, ACIOL, different sutured lenses. What is your sort of indication if you were to use a suture in which patients?
If it's left to me, I would always do a AC lens. I don't do these sutured IOLs. I have an anti-segment surgeon who comes in and does it as a combined surgery. So I don't have much experience of these techniques myself.
Pramod?
I do most of the time suture lenses. Rarely do. Yeah, I think I had not done Yaman just one case probably, and glue IOL only a couple of cases. But I prefer suture lenses nowadays. I use Gore-Tex. But this technique again, yes, I use lot of cases, as Dr. Ramandeep said, coming up 3 years back. I think year 18 I presented this in one of my free paper. Similar technique, more or less. So what here important thing when you do this technique is ensure a good vitrectomy is done. Otherwise, the haptic can be hanging in a vitreous cavity, and you just lift the lens and put the needle through. You can dragging vitreous along with that. Just ensure eye is well vitrectomized. If not done vitrectomy, please complete vitrectomy. And when you pass the suture, when a suture goes around, it should be look around the haptic, because if you go through the eyelet and it goes over it again, there is chances of IOL tilt. That is second problem. Third is couple of cases what we had when you tie this suture, by the time you fix this suture, other suture gave way, because it happened twice that also. So you have to take all those things into care. Yes, but this is an elegant technique, very quick and minimum manipulation. So that's what exactly I also do. What I agree with Dr. Ramandeep.
Shobit?
My experience is of removing the IOL and replacing with the Lamane technique. And if I have done some posterior segment maneuvers which required fixing a break or a retinal detachment, then I don't, and if the endothelium count is good and healthy, I go ahead even with an ACIOL. I have no reservation.
Can I make a comment?
Yes, Hemant. Yeah.
Yeah. Now, I think this is a good technique, because a lot of times what happens is the other haptic is firmly fixed. So it's very difficult to take it out. Sometimes it just comes out, but otherwise removal of that, you need to cut the haptic. So here is a
unless if it's hanging by one, it's different. But it's totally dissociated, then you have to.
Then it's fine. That's fine.
So I think all these cases teach us, there's a lot of these cases, Ramandeep showed very nicely that they look great on video, but when you start doing them, there's called retina gymnastics, that these lenses move around, the suture moves around. And then not like a case like this, but sometimes I see people doing sutured lenses in people who are 65, 70 years old. And that leads to more sets of complications. So sometimes you have to wonder, like, what's the indication? You know, young patient, angle problems. But I think ACIOLs have become so good that once you start doing retina gymnastics, then you start thinking, maybe I should have just put an ACIOL in and have the 70-year-old man have at it, because a lot of these cases come back 10, 15, 20 years with either dislocated IOLs or tilting or those sort of things. So I think there's a place for these lenses, but sometimes I see them being put in 75, 80-year-olds, which to me doesn't make any sense. Unless
Even
they've got
suture-related problems. Related to the suture, there can be excoriation of the suture and issues.
Exactly. So, Anand, any comments?
Yeah, no, I usually prefer the Gabor-Sharia technique of, tucking it into the scleral flaps if it's a primary for an epic case. But in this case, I mean, with one very secure suture, I guess Ramandeep was left with little option other than, going
Of course.
way.
Yep.
So I think I did a great job there. So terrific. I think we'll move on. I think we have another IOL related case. So previously we said we were hoping that cataract surgeons weren't watching, but now I hope they are.
Yeah.
So this was a unique problem. This lady had two lenses, one in the vitreous cavity, one in the sulcus. She's diabetic and she has asymmetric diabetic retinopathy. Her daughter was really worried. She wanted the things to be out. So I said, I will try and remove it minimalistic approach. I made this nice scleral tunnel and just thought that I will not touch the lens in the sulcus and I'll just slip out the lens from behind it without even letting it know. This is what I did. My scleral tunnel works very nicely and I could take out that lens. I don't have to cut the lens, and this was a nice outcome in the end. This was a kind of a minimalistic approach to take out the lens behind. Thank you.
I think very nice. I think Ramandeep, I think what's happened is fellows and residents, quite honestly, they don't do that many tunnels anymore, right? I think that's the problem. So in order to do tunnels, it's just like buccal sutures or any of these things, that skill has been lost. So this shows you very nicely of having a tunnel and not having iris come in there wound all the time. I mean, it's a really simple procedure that you made it elegant. So any comments? We'll start with Pramod and then Manish and then Shobit.
Yeah, I would say Dr. Ramandeep is excellent surgeon. Okay, so very good job he has done. I had one case where one IOL was in antechamber, other was sitting on the disc. So in that situation, I could just slip that lens in antechamber from the edge of the AC IOL without disturbing that. I could remove. But I think that's a given scenario. What he has done is the best thing to try to retain. But I would not hesitate to remove both the IOL if necessary. If necessary.
Yeah, I think if it's required, you remove both. But even I've had an instance where not an AC, but a sulcus one, which I could just tilt and remove the one behind. So a few times in an individual situation, you could have that liberty of retaining the lens and then taking out only the posterior one. But otherwise, you have to remove both and then plan whatever secondary IOL that you put in.
I have a case in which there is a foldable IOL in the inferior vitreous base and there is a sulcus IOL, and I've been following up the case for around 5 or 6 years and the patient is doing fine. So we can also observe and see if it is needed. He's a one-eyed patient, so I don't want to create more problems for him.
Yeah, no, I think that's
Rigid
right.
haptics or Prolene haptics?
No foldable, no non-rigid.
Yeah, I would do that. If there's an issue here, if vitreous is liquefied, IOL is freely mobile, probably I would prefer to remove. It is stuck somewhere at 6 o'clock in a gel vitreous, not moving at all, absolutely stationary. Patient is not keen for surgery. Yes, I have one coloboma patient having one IOL in, one is almost 10 years, and I keep on telling that better you go out, get the IOL out. And he says, doctor, you keep on telling me every year and see nothing is happening last 7-8 years. How I should believe you?
Yeah, and I think another approach for this, if you don't want to put an AC IOL in, just make a pars plana tunnel incision and just take it out that way. So if you don't want to touch the cornea or have endothelial problems, but very nice video showing very nice technique of just a retina person scleral tunnel. So next case, Anand, unless there's any comments. I think Anand, you're mute.
Good evening, everybody. It is case of retinal detachment. where I settle the retina, doing the laser, keeping the PFCL over the retina. Now I'm aspirating the PFCL. So PFCL bubble, I have to aspirate it out and to inject the silicone oil. Then I've seen a lot of PFCL droplets are there overlying the macular area. So I used silicone tip backplus needle to aspirate all the PFCL droplets from the macular area, which are lying in front of the retina. Now, after removing all the droplets, I have seen few droplets are still there in the infratemporal macula. So I tried to remove all the droplets, but it was not coming out. Then I have a look in a magnified way. Now keeping the endolimiter close by, and then I discovered it is not anterior to the retina. Now it is posterior to retina. It is in the subretinal space, multiple droplets. Just imagine how much of irritation a surgeon can feel after just finishing the case. All the like quite a number of subretinal PFCL droplets are there. So I plan to remove it by creating a small paramacular retinotomy infratemporally close to the droplets, keeping the IOP a little bit higher side, around 50. Then I inject PFCL to have a like complete removal of the all PFCL droplets from the foveal area. Now removed all the droplets, and finally I did laser around the retinotomy. The alternative I could have do that, what could have done, I make the infusion on again, created the detachment again, then removed all the subretinal PFCL bubbles removal, then followed by settling the retina again, half an hour extra. So just to avoid have a quick management, I created this retinotomy. Whether it's right or wrong, it is up to you people and on the panel. Just have a discussion.
Dr. Boral, very, very nice presentations. There are no right or wrong answers. These are just different managements. So Hemant, two questions. Now, the first one, maybe you can answer, and then followed by Manish, is how do you avoid this in the beginning? How do you?
Yeah, I was about to come to that. I think the first step is that you need to avoid the bubbles, because once the bubbles form. So one step is that when you inject the PFCL, the first you inject into the bubble, the first bubble rather than. And the second thing is, if there are leakage from, if you're using non-valve cannulas and there is turbulence, that's when the bubbles form. And if the valves are also reused, then sometimes there is leakage, and that's when bubbles come in.
Use combination, 2 valve cannula, 1 non-valve cannula to inject because of the silicone tip, using the silicone tip cannula. That's why I'm using 1 non-valve cannula. That was the main reason.
I think again, turbulence.
I'd like to add one small point to what Hemant has said, that use a tri-way on your infusion also, and reverse the tri-way when you are doing your PFCL injection to decrease the turbulence further. This have to
I would like to add here.
Avoid fish eggs.
Pramod?
What happened here is basically we need to see why it happened. Previously, we used not used to see so many complications like this. We started using now so-called IOP compensation machines.
Yes.
Okay. So what happened? The moment there is a fluctuation, you have a jet of fluid, and you create a turbulence, and your PFCL breaks into multiple droplets. And if you have a larger break somewhere periphery, this slowly, as long as central large bubble PFCL is there, you do not realize these small bubbles are seeping through those breaks. And as you start PFCL taking out, along with that, these bubbles start going down under the retina. And when you finish, you see these multiple bubbles in subretinal. It's quite annoying. I agree with Subhendu. But that's what we need to understand. The two things what you can do is, one is reduce the IOP, what Anand has discussed previously. For first session, we saw around 20 or 15 while injecting PFCL, or particularly when you exchange the instrument. That time IOP should be at a lower thing. So what happened? You prevent the turbulence. Yes. That is one thing. Okay. Or other option is to have a double bore cannula, what Hemant was talking about. That's what I use sometimes for injection of PFCL, so that instrument exchange will be less, turbulence will be less, you have a fill uniformly, and ensure that basically minimize instrument exchange. That's it.
Manish, how would you manage this? We've talked about why we got this, but how would you manage this? Any
Manish is
different?
not there. Manish
Oh,
is not there.
Yeah,
Manish is not here.
Okay.
Manish has left.
Manish had to leave actually. So,
Oh,
Dr. Hemant, can you take that?
Or
Pardon?
Hemant,
Can you come again, please?
I said, how would you manage this? Anything different in terms of management?
And I think he's managed it well. I appreciate his surgery because the other than that, I think because he tried to remove all the bubbles that were close to the macula, I think he has done a good job. I would probably do something similar.
Yeah, I would also do the same. I mean, it was very well done,
Do
and
the
it
same.
should get almost everything off the macula. That was critical. Yes, Ramandeep, go ahead. You have to unmute.
Mandeep, go ahead.
Yeah. So I heard saw this technique that would you put more PFCL there to let that PFCL bubble go towards the periphery and then make a retinotomy there? How about that? Put PFCL again and push that PFCL bubble towards the periphery.
I did it. I did it.
That's what
I did
Subhendu
it.
Yeah, sometimes it works, sometimes doesn't work because sometimes PFCL just run over it.
Yeah.
No, I did
because
it.
of stress. Yes.
I first created a retinotomy, removed as much of bublet removal as possible, then injected PFCL also to remove the residual bublet.
So I think he was talking about before you make the hole is to push the PFO towards the periphery. So
Yeah, that's right.
So the hole is not so much in the posterior pole. I think that's another a good option.
Yeah.
And Pramod, the reason why this would occur is because it's a fresh case. It's still not settled. Once we have gone through this and a later date, it doesn't come up.
It is, yes, that is true. That is.
And I think for people using PFO, as somebody had mentioned, these small bubbles will be typically at the vitreous base. As you're going down, then they're getting underneath the retina. So it's really
that's right.
So I think we have one quick comment and then we move on from Dr. Joshi.
Sir, I think Subhendu sir, you have done a nice job. The only thing I wanted to add is I had a couple of such cases where I had retained PFO. So in those cases, I use a 42 gauge needle.
No, that is the postoperatively. Now it is just freshly done intraoperatively. You realize
even intraoperatively, can you use the 42 gauge with that? Can you induce a detachment rather than making a large break and then with the
I have done
injector?
That break has enlarged. I made a small retinotomy. You have to remove all the bublets. That's why you have to create the retinotomy. Otherwise, you have to make the detachment, inject PFCL, then through your existing anterior break, you have to remove all the drugs. This is a long procedure. So what I did, it was a quick kind of management, creating a small paramacular retinotomy. That we can also do.
Sure. Thanks. Thanks a lot. We'll move on to the final two presentations. Sai, can we have the video on quickly?
1 second, Sai. So this, can play. So this was a case with a subretinal hemorrhage here. The patient presented, and can you just pause it, Sai? Can you go back again? So this was what he presented with, the subretinal hemorrhage. So at this instance, I did the pneumatic displacement with C3F8 and Ziv of aflibercept. He came back after 3 weeks with massive subretinal hemorrhage. So post 3 weeks, I started seeing that there was a massive, so the only thing left to me was to drain it surgically. So I went ahead, did a vitrectomy and did a PVD induction in this case. And now you can see as I started putting the PFC, I'm just throwing the subretinal hemorrhage to one side so that I can make a retinotomy in the periphery and try to drain as much of subretinal fluid comes out through that. Did a multiple fluid air exchange and did a laser to that retinotomy. Now you can see there's only posterior pole blood is remaining. Rest all the blood had cleared pretty well. But the patient developed RD later on. Though the blood had disappeared completely, the patient developed RD. So I went ahead, did again indented base shaving and tried to look in for if there are any peripheral breaks which cause this RD. But I again injected PFCL to find it. And now you can see the RD is just bullowing up, but I'm not finding any breaks in the periphery. Then I thought whether that subretinal TPA injection which I injected, that site gave up and caused an RD. So periphery, I found that there was no peripheral breaks and I had to make a retinotomy and finally drained the subretinal fluid and did a laser to that break. And I used intraop OCT to check whether that the subretinal TPA site had any break, which this is the rewind video I'm just showing. There's a slight pull while pulling it up. It's a slow motion video, but in the intraop OCT, I could not find any break on the posterior. But anyway, I went ahead, did a 360-degree barrier laser. And this is the post-op picture. The subretinal hemorrhage went away, the nicely settled. And now you can see the pre-op from 160, the patient improved to 614. And the patient is doing well now, and he's maintaining well. So the question I wanted here is, when the first pneumatic displacement I tried, and 3 weeks later when the patient presented, could it be a fresh massive subretinal hemorrhage which had gone through, or what went in this case in the first instance?
Srinivas, can I make any comment?
Yes.
So let me just make one quick question, and then we can have comments. Is what did you think the etiology for the hemorrhage was? Was it polypoidal macroaneurysm, AMD? Like, what did you
exactly?
It was a case of PCV.
PCV. Okay, so you thought the hemorrhage was PCV. Okay. All right. We'll have one quick comment, and then we'll go to the panel, which starting with Shobhit in terms of management. Somebody had a comment?
Yes, Srinivas, I think it is a case of PCV, and you have created the macular rosary in macular hole. You have not noticed any break.
No.
I think macular hole was there.
No, sir. There was no macular hole. I used intraop OCT. I used the flat lens. I usually screen since I'm having the intraop OCT, I usually screen over the posterior pole. There was absolutely no macular hole at all. But the first thing, why did that became so huge hemorrhage? But I had called the patient to come back after 1 week. He came back after 3 weeks. And I had injected C3F8, which usually lasts around 4 to 6 weeks. But it caused very massive subretinal hemorrhage for me to go and intervene surgically.
So Pramod and Shobhit first, and then Pramod, do you do pneumatic displacement in the office like this, or in terms of anti-VEGF and gas? Shobhit first, and then Pramod.
For such a massive hemorrhage, I like to go in, do a good vitrectomy, do TPA, 25 microgram underneath the retina, 25 microgram in the vitreous cavity, leave it alone, drain, wait for some time, do a repeated fluid air exchange, remove as much blood as possible after it comes out, and then leave it with 10% C3F8 and observe the patient closely. And I like to call these patients back after a week, reassess, and if need be, do a lavage. If I find any break which is there at that time, I like to treat it.
Pramod?
Normally, these patients, we see quite a few of them.
Yeah, basically,
us, we see a fair number of these cases every year, and most of them do fairly well.
Pramod, and then Hemant.
Yeah. So to answer Srinivas's question, yes, the small amount of hemorrhage what he initially showed that's under the fovea, yes, we do pneumatic retinopexy. Probably I won't inject anything on the table. Have a pneumatic retinopexy, if I can displace it, then I would do FFA or ICG or anything and then take a call. Okay, that is one thing. But it is not unusual to see this massive bleeding subsequently. I don't think it's unusual. We see quite a few cases. But when you have such a massive bleeding, in general, it is practically impossible to take out the blood. Hats off, I'm really surprised how he managed to get all this blood out and squeeze out, because within few days, this blood is totally clotted. Unless you do large peripheral retinotomy, is extremely difficult to take this blood out. Going in general, prognosis is not really that great. So in fact, I would ask patient, give him option, whether really you want to go ahead with surgery or not, repeated counseling, because quite few, because doing large retinotomy peripherally, get this blood out, high risk of PVR, it's a lot of messy affair. So counseling, and if this is only eye, there is no other choice, then only I would enter in this eye.
Hemant?
I think I would do very similar to what Pramod said. I would do pneumatic, just gas injection and try in the mild case. But natural course of PCV is such that massive hemorrhages are known to occur. So I think I would probably do the same as what.
I think this is very well managed. The only other thing another option is to do also subretinal air along with it when you have a massive.
A small bubble with the TP.
Yeah, so that has worked pretty well for me. But you know, these cases that the natural history is not good when you have a massive hemorrhage like this. So I think you're to be congratulated for what you did. So Anand, I think we move on to the next one. Last one.
We move on. Great job, Srinivas. Not easy to manage these cases. Some macular surgery is something difficult. We'll move on to the final case for today. Gopal Pillai talking about.
Okay, this is an endophthalmitis, post-cataract surgery endophthalmitis, in which we had done almost complete vitrectomy. And once it is all over, I was just injecting vancomycin and ceftazidime at the end of surgery. And then when I went inside, I saw that there is a bleed. So now there's a total vitrectomy. Now it is under air. There's no vitreous cushion because it's not a core vitrectomy, it's a complete vitrectomy. So what happened was there was the tear which formed because of the jet stream of vancomycin and ceftazidime injection. So fortunately, it was slightly away from the fovea, and we could manage with laser, and I had put oil in this case. Otherwise, I had not actually thought about oil. Because of the tear and end up, I put an oil. So this is something that we have to take care. You know, slow, you know, drop by drop injection. No, just thank you.
No, I think that's a very good point. I mean, one of the ways I do is if I do antibiotics, I just use a 30 gauge needle and put the tip towards the IOL. And that way there's nothing in the posterior pole. But again, I think these are all lessons to learn that just, you know, the famous words, everything was going well until this, right? So that's the problem. Anand,
why did you injected air? Sorry.
Oh, no.
Sorry, go ahead, Dr. Pramod.
Yeah, why he injected air in this eye? Because he was planning only core vitrectomy, right? So
no,
you
I
get
did not, this is not a core vitrectomy. This is a complete vitrectomy. I had induced PVD. I had removed all the you know, vitreous in the periphery as well, and I finished with an air fluid exchange.
That's why if there is no break, why you are injecting air? Because and then I agree, like a jet stream injury, I agree with that. But if it's a fluid, it's a no break, why you want to have air inside the eye? Why you want to leave air?
Were you planning to inject oil inside?
No, I was not planning to inject oil. I just did an air fluid exchange so that the final vitreous exudate in the periphery, that will all come when you are doing an air fluid exchange, it will all come to the posterior pole, and that also I will be able to take out through the air fluid exchange. So in these cases, I would do a partial air fluid exchange to you know, so that when the patient is sitting up, both the ports will get supported with the air.
So Shobhit, this case didn't need it, but let me give an example so people can learn. What if you have an eye that you have to put oil in, and that has oil in the eye and has endophthalmitis? What concentration of drugs do you put in? The full concentration, half concentration? Give me your thoughts and Pramod, and then Hemant.
After fluid gas exchange, we put in the regular concentration because it's a accepted dose before putting in the oil.
Exactly. Okay. Pramod, what do you do? Anything different?
Yeah, if it is air or oil, because the drug is going to sit directly on the retina, as against when you have fluid filled eye. So the localized toxicity is reported. So probably, yes, there is a controversy. Do not have any proper answer to this question, but probably I would go with a half dose, assess later on, and then take if necessary next day or subsequent day I can inject if necessary later on, but not when only air or oil, because oil in antibiotics is getting the sandwich between the retina and oil or gas. So you have a local concentration will be much higher. It doesn't get diffused.
Got it. Hemant?
Yeah, I think the volume of distribution now becomes very much reduced. So I think I would also go with half dose than the regular dose.
There's always a meniscus of fluid between the oil bubble because it's never a complete fill.
Yeah, so the meniscus actually produces lower volume of distribution. The volume of distribution of the drug now becomes very much reduced. That's the problem.
Anand?
But it has to be titrated between the control of endophthalmitis versus the toxicity of the antibiotics.
Yeah.
So,
but remember that the amount of antibiotics we put, even with a regular dose, the MIC, it is such a high dose that it's probably 1,000-fold to what you need to kill something. So even if you use half the dose, you're going to be fine because you get such high, you know, it's concentration. So Anand?
Yeah, so my first observation here is like just a comment and take on what Dr. Pramod also was saying is that I would not have put in air. And as a principle for end of cases, it's either saline filled eye or oil. I wouldn't put air because the reason is air, you know, within few days it'll go, and on inflamed vitreous and retina that's inflamed and infected, that can pull and can actually cause tears. So I usually would never go in with air as a damper.
Not an expensive gas.
But again, coming to the question of the oil fill, most of the time, since it's not a totally complete, I usually go with the same regular dose. But in very bad cases, I would half the dose too.
Okay.
Yeah.
I think, is that it?
Yeah, that's it. Any audience questions, Dr. Hemant? You've been he's tasked with that. Any questions pertinent to this section or anything outstanding?
Nothing specific.
Not covered.
So we can now wrap
I think
up.
most of the
It was a very
questions.
wonderful discussion. It was a wonderful discussion.
Yeah. Thank you. It's been a pleasure having everybody here. Fantastic efforts by all the presenters. Thank you so much, Dr. Gaurav, for being here. I'd like to invite Dr. Shobit to give the final closing comments. But thank you so much, everybody.
Thanks a lot to all the speakers, first of all. Ramandeep, Subhendu, Gopal, Vishal, and Srinivas. Special thanks to our panelists, Hemant, Manish, and a great thanks to Anand for putting all this together. And most of all, a very special thanks to Gaurav for helping us with this session, first in the last VRSI and now in our third webinar of VRSI during these times. And thanks once again, Gaurav, and we would like to, only topic I feel we have not covered today is diabetic vitreous surgery. We would definitely like to do a surgical webinar on that, and we would definitely like to trouble Gaurav again for that.
Sure, it's my honor and pleasure. And I think there's in these meetings, I think the panelists learn as much as from each other as from anything. And as I said, with surgery, there's no right or wrong way. It's very easy to look at things retrospectively, but that's when you learn the most. So again, I think a big thanks to all the presenters, the panelists, obviously big thanks to Anand for putting this together, and also to the AV person, Sai, that this was flawless. And I think that, hope to get together in person with you in December, God willing, and COVID, that we should all be okay.
And
thank you, Sai.
Thanks, a special thanks to Pramod for sharing all the lovely.
Of course.
Thank you, everyone. I think
thank you, sir. Thank you so much.
Thank you very much. And it's nice seeing you all of you. Have a wonderful continuation.
Thank you, Sai.
Anand, I think this was it was very good because we had so many videos playing flawlessly all throughout. I think this is very nice.
Very nice.
Thank you, everybody. Thank you.
Thank you, sir. Good night.
Bye-bye.